Welcome to the ACE Hot Topic webinar, How to Guide NAPRC Accreditation. I'm Jen Wood, Meetings and Administrative Manager for ACE. I have a few housekeeping items before we begin. First, if you have not done so already, please renew your ACE membership as the ACE membership year runs from July 1st to June 30th. Please visit www.cancerexecutives.org for additional information. We hope you can join us for one or both of the upcoming educational events. First up is the International Oncology Leadership Conference being held November 17th to the 19th, 2019 in Antwerp, Belgium. Secondly, please join us for the 26th ACE annual meeting scheduled for January 22nd to the 24th, 2020 in New Orleans. Registration for the ACE annual meeting will open in the next several days. Please visit the ACE website for additional information about either of these educational conferences. This webinar is being recorded and will be posted to the members-only section of the ACE website. We will be holding all questions until the end of the webinar, so if you think of anything during the presentation, please submit your questions through the question box in the GoToWebinar toolbar. It gives me great pleasure to introduce today's webinar speakers, Dr. Lijo Simpson and Dr. Leigh Webb. Lijo is a board-certified hematologist and medical oncologist with Atlanta Cancer Center and practices at DeKalb Medical Center and Southern Regional Medical Center in the Atlanta area. He has been named to the Atlanta Magazine's list of top doctors from 2013 to 2019. He has published numerous articles outlining his research in colorectal, genitourinary, hematologic cancers, and melanoma, and has also presented extensively at ASCO, the American Society of Hematology, and the American Society of Bone Marrow Transplantation. He has over 8 years of research experience as a principal investigator and sub-investigator in numerous phase 2 to 4 trials. Lijo completed his fellowship in hematology and medical oncology from the Mayo Clinic in Rochester, Minnesota, and his residency from Advocate, Illinois Masonic Medical Center in Chicago. Leigh is a manager of the Cancer Data Center at WellStar Health System with over 15 years experience in managing data analysis, quality projects, and accreditations. Leigh is a certified Lean Six Sigma Black Belt. Leigh specializes in quality outcomes and regularly presents outcomes at national and regional conferences. A strong believer in quality management, Leigh integrates data with Lean Six Sigma concepts in order to prove processes. And without further ado, I welcome Dr. Simpson and Dr. Webb. Take it away.
Thank you, Jen, and the Association of Cancer Executives for organizing this timely and important webinar. On our agenda today, we will define the scope of the problem around rectal cancer, do an overview of the reasons why the National Accreditation Program for Rectal Cancer, NAPRC for short, was created, the key principles of the NAPRC accreditation, steps towards achieving accreditation, and some of the challenges we have noticed around collecting data and achieving this accreditation. We will finally transition to Leigh from WellStar Hospitals, who will talk about the steps they are taking towards achieving the NAPRC accreditation in 2020. We'll start with the origin of the NAPRC. Rectal cancer affects around 45,000 patients in the US annually. So there is a high disease morbidity in North America. It was observed in the late 1990s that the outcomes of patients in Europe were better than the outcomes of rectal cancer patients in the US. This observation led to the creation of the Ostrich Consortium, initially representing 11 programs under the Cleveland Clinic, and this led to the results being presented to the COC to help them create new standards around rectal cancer accreditation. An overview of the problem. Riccardi et al. Studied 20,000 proctectomies undertaken between 2002 and 2004 and analyzed county data in 21 states. It was observed that there was a 50% rate of permanent stoma construction, and only 20% of the counties offered a colostomy rate of less than 40%. These were poor outcomes. A more recent paper highlights this problem even more. The American Society of Colon and Rectal Surgeons, ASCRS, has a rectal cancer surgery checklist that is a consensus document of high-quality rectal cancer surgery. It lists 25 essential elements of care for all patients who undergo radical surgery. Now, this study was done in a high-volume center, academic center, and still low compliance rates were observed with many of these metrics. For instance, the documentation of sexual function and continence was 0%, and a tumor board discussion of patients with this complex cancer happened only in 16% of patients. In a high-volume center, you would expect higher compliance. The conclusion of the authors of this study was that checklist compliance within a high-volume specialty academic practice remained varied, and they recommended taking numerous steps towards improving this checklist. So if this is happening in a high-volume center, you can clearly see the scope of the problem. This was the same situation that existed in Europe in the 1990s. Some of their studies of rectal cancer outcomes showed a 5-year survival rate of 38% in some trials. Certain key initiatives were taken to address this problem. They centralized their rectal cancer care in centers of excellence and introduced multidisciplinary discussion of their rectal cancer patients. With this, they were able to demonstrate an improvement in rectal cancer outcomes. For instance, one of the papers looked at the Stockholm TME total mesorectal excision project and showed that by following these metrics, their local recurrence rates was decreased from 21% to 6%, and a change in process only resulted in an increase in the disease-free survival from 60 to 65% at 7 years, and there was an improvement in sphincter preservation. The addition of multidisciplinary coordinated management of patients with rectal cancer, especially involving radiation therapy given preoperatively, resulted in the local recurrence rate dropping even further and further survival improvement. Thus, we can see that there is data that multidisciplinary coordinated management of these patients helps improve outcomes. These results were then extrapolated to the other European countries, and publications came out from Denmark, Spain, Belgium, and the UK showing a reproducibility of the results. This data, coupled with the variability in the care of rectal cancer patients seen in the US, led to the creation of the Ostrich Consortium in 2011. Ostrich stands for Optimizing the Surgical Treatment of Rectal Cancer. This consortium involved several societies, including the College of American Pathology, the American College of Radiology, American College of Surgeons, the Commission on Cancer, the American Society of Colorectal Surgeons, Society of American Gastrointestinal and Endoscopic Surgeons, Society of Surgical Oncology, to try and ensure representation of clinics, universities, suburban, urban, different types of settings, so that when we implement guidelines for rectal cancer surgery, this is reproducible and this relevant to different settings where patients with rectal cancer are being taken care of. The Ostrich Consortium performed several analyses and culminated in a series of publications, and they highlighted two problems mainly. One was the variability in rectal cancer care, and second was the suboptimal care in the US compared to countries in Europe and UK where rectal cancer centers had been created. The consortium reported these findings to the Accreditation Committee of the Commission on Cancer and the officers and regents of the American College of Surgeons, and that led to the development of the National Accreditation Program for rectal cancer. Now that we have highlighted the problems around rectal cancer care, let's talk about some of the standards that may help us solve this problem. The NAPRC is designed around three broad pillars. We have to have program management that ensures the presence of a director to oversee the entire program. Clinical services have to be managed to ensure best practices in multidisciplinary care, documented by measuring key metrics around rectal cancer. And lastly, quality improvement has to be demonstrated by participating in the RQRS, and that the estimated performance rate is met for each accountability and quality improvement measure. To achieve accreditation, the program must establish a multidisciplinary team with the 5 required disciplines of surgery, medical oncology, radiation oncology, pathology, and radiology, as we do for COC accreditation. Alternates can be designated for attendees in the multidisciplinary cancer team. The surgeons cannot have alternates, as all surgeons who perform rectal cancer surgery are required members of the multidisciplinary team. The programs must adhere to evidence-based procedures, especially around total mesorectal excision, the College of American Pathology synoptic reporting for pathology, and synoptic MRI reporting, very similar to Cancer Care Ontario's MRI template. The current NAPRC standards are available at this web link in the FACS website. And these are across the 3 categories of program management, clinical services provided, and quality improvement. Specific questions on the standards are best targeted to the CA Answer Forum, which is a resource of the American College of Surgeons. A key point to note is that the Commission on Cancer is trying to create overlap within their standards so that you can achieve accreditation in a more simpler and a clinically meaningful fashion. The draft COC standards that were released in May of 2019 has as standard 5.8 total mesorectal excision of rectal cancer as one of the standards, indicating a level of harmony between the new COC and the NAPRC standards. Why should programs consider NAPRC accreditation? We clearly know that there is variation in rectal cancer outcomes in the US, and this is one of the ways in which we can work towards improving outcomes for our patients with rectal cancer, specifically around lowering the recurrence rate, lowering the rates of permanent colostomy placements, and higher survival for our patients with rectal cancers who come to our centers. In addition, we can capture several existing processes under the umbrella of accreditation and improve the quality of care. Accreditation also helps us stand out in the community as a high-quality cancer care destination. Several programs are consequently exploring this accreditation, and many will follow suit for these reasons. Let us now look at some of the steps required to achieve accreditation. Please note that a comprehensive review of all these steps is beyond the scope of this presentation. We will provide an overview here of the high-level requirements, but please refer to the standards manual for a full list of requirements. To achieve the standards, the facility has to be accredited by the COC. So you already have certain baseline accreditation requirements of the COC, and this will build on that. You have to attest that the NAPRC standards are being followed for at least 12 months, including participation in the RQRS and presenting the rectal measures to the Cancer Committee. You need to establish a rectal cancer multidisciplinary team that tracks attendance. A 50% attendance for members and alternates is required. We have to include all the surgeons that perform rectal cancer surgery at your facility. Rectal cancer multidisciplinary team meetings must be held twice a month. One member from each specialty should be present. A rectal cancer program director chairs the rectal cancer multidisciplinary team and is the liaison between the rectal cancer program and the COC committee. The director should report the NCDB data to the rectal cancer multidisciplinary team 4 times a year, and the rectal cancer program coordinator is another required member who coordinates all the functioning of the program. Surgeons have to complete an NAPRC endorsed education module. Pathology should be familiar with the College of American Pathologists Cancer Protocol for the examination of specimens of patients with primary carcinoma of the colon and rectum, and the radiologist completes the NAPRC module. This ensures to our patients with rectal cancer that the team of surgeons, pathologists, radiologists, everybody who is part of that multidisciplinary team has a certain level of training to take care of these complex patients. A few must-have: every patient with rectal cancer should have a treatment planning discussion, and 50% of those patients should have recommendations provided to the primary care or referring physician. Also, an outcomes discussion must be conducted within 4 weeks of rectal cancer surgery, and 50% of those patients should have a treatment summary provided to the patient and their primary care and referring physician. Data has to be collected for accreditation. And this data falls under the 3 baskets of pre-treatment metrics, treatment metrics, and post-treatment metrics. For all rectal cancer patients, the clinical services required before treatment pertaining to their surgery is best formatted and collected as a checklist. MRIs should be in a standardized format along the lines of the Cancer Care Ontario template. A treatment recommendation and evaluation summary should be completed and provided to the primary care or referring physician for at least 50% of the patients. Pre-treatment CEA has to be recorded. That is one of the metrics. It is important to track where the tissue diagnosis is done, whether it is done at your facility or an outside facility. Treatment metrics. The American College of Colon and Rectal Surgery Rectal Cancer Checklist was the guide used for the development of the standardized synoptic surgical report. The required elements are outlined in the appendix of the Rectal Cancer Accreditation Manual. 95% of the surgical reports should be in the synoptic format. Likewise, the College of American Pathologists synoptic reporting format should be utilized to report on rectal cancer pathology, and photographs of the anterior, posterior, and lateral view of the surgical specimen should be obtained and reviewed by the team in 65% of the cases. This is very important because each of these metrics has been shown to predict for better outcomes for patients with rectal cancer. Post-treatment, for a rectal cancer program with 100 or more cases, the rectal cancer program director may develop criteria to determine which patients must be presented at the rectal cancer MDT for a treatment outcome discussion. Regardless of the criteria, at least 100 cases should be presented for treatment outcome discussion, And a treatment summary has to be presented to 50% of eligible rectal cancer patients beginning within 8 weeks. If a patient requires adjuvant therapy, that treatment should begin within 8 weeks of the surgery. And all these metrics have to be documented. Some of the challenges we have noticed in acquiring this accreditation, or that you may face as you go through this process, is the tracking and monitoring of these metrics. The registry staff is already overwhelmed from the changes that recently happened to the registry metrics that require to be monitored. In addition, tracking these metrics on a paper or Excel file does not help you stay on top of any deficiencies. So utilization of technology solutions to help you collect these metrics, track and generate reports to rapidly identify and correct deficiencies. And ideally, if that same platform can help you create a treatment evaluation and recommendation summary and route it to the referring physician, and also help you create treatment summaries and route that to the referring physician, then this will be highly beneficial and potentially save a lot of costs in achieving this accreditation, and also can help with achieving other accreditations or maintaining other accreditations that your program has. I will now transition to Leigh Webb from the WellStar Health System here in Georgia. OncoLens had the honor and privilege to work closely with and assist WellStar in establishing the data collection and reporting mechanism to support their needs. We will hear about their exciting experiences in putting into action the steps required for accreditation.
Thank you, Dr. Simpson. I'm Leigh Webb, and I'm very excited to show you just a little bit about our journey in pursuing NAPRC accreditation and the invaluable resources that we have with OncoLens to help us achieve this accreditation. WellStar Health System is a non-for-profit health system and is the largest system in Georgia. We have 11 hospitals, 225 medical office locations, as well as other healthcare services as well, inpatient and outpatient. And we pride ourselves on delivering a patient-centered model of care. WellStar is an early adopter of new technologies and quality programs historically. And so it was a natural, easy decision to pursue NAPRC accreditation so that we could ensure that we are providing the best quality care to our patients, which is exemplified in our vision of delivering world-class cancer care. So in January of 2019, we worked with OncoLens and piloted the platform within two of our largest tumor conferences. We did a 3-month pilot and went over very well. So over the summer, we were able to extend the platform to all 13 of our cancer conferences throughout the WellStar footprint. Our physicians and their assistants, administration found it very easy to use the app and enter patient information that is needed in order to present the case at a tumor board. They're actually able to do it while they're in the office with the patient. They're not having to wait and maybe forget about that. It can all be done real time. So then when we started in the summer, well, started in the spring looking at NAPRC accreditation, I wanted to see, kind of get a roadmap of how much data we were going to be collecting and how we were going to collect that data. We were very overwhelmed, didn't quite know how we were going to track everything, especially with all the timing mechanisms and metrics that are within the NAPRC accreditation. But then we noticed that a lot of the data that we were going to need was already in OncoLens. So we worked closely with OncoLens team to incorporate capabilities and reports, to put in the pre-treatment, treatment, and post-treatment metrics for tracking that directly align with the NAPRC guidelines. So OncoLens rectal tumor board workflow optimizes this collection of the NAPRC metrics. We're able to click a box and run a report, and that's pretty much all you have to do to get that information. One thing that we struggled with was how are we going to determine when the patient needed to be presented the next time. And as Dr. Simpson alluded to, it's too cumbersome to keep Excel spreadsheets with all of this information. So if we have a patient that we're presenting today at the rectal cancer program meeting, and that patient needs to be represented within 4 weeks after surgery, we can go ahead and schedule that patient for 4 weeks through the OncoLens system. That is a huge game changer for us to be able to use this system and not have to manually keep calendars and a lot of manual work to get this done. We're able to track attendance real time with all of the specialty designations, and as Dr. Simpson said, the attendance is a requirement and can result in deficiency if it's not met or tracked. We're able to run the pre-treatment, treatment, and post-treatment summaries at the touch of a button from the program. And at WellStar, we have some medical specialties that are in private practice, so there is a breakdown of 100% sharing of records. But OncoLens has that capability of where we can electronically share this information back to the referring gastroenterologist or primary care physicians. That way all physicians who are involved in that patient's care have the same information. So as I said, we kicked off our program in July 2019, and we are seeking our final accreditation in summer of next year. We have so far monitored 44 rectal cancer patients within the OncoLens platform. And the physicians are able to upload the information in real time, and it helps to facilitate a very smooth tumor board because all of the information is readily available to them within this one platform. We're not having to switch between computers to look at pathology, to look at radiology. Everything can be uploaded into the platform, and it can be one smooth program. And one of the most I think game-changing things that OncoLens has is the clinical trial information, where they can, based on the tumor type, the primary site, as well as the stage, we can match patients directly through the OncoLens system to any clinical trials that are within the area that could be suitable for that patient. That's all I have.
Well, thank you very much, Leigh. We will now open for a Q&A session.
Thank you so much to both of you. As a reminder, if you have any questions, please submit them through the questions toolbar through GoToWebinar. And I would also like to introduce Andrew Matthews. She is CEO of OncoLens, and she will serve as our question moderator.
Great, thank you, Jen. While we're waiting for questions, in fact, I'll start with a couple that we received yesterday. And Dr. Simpson or Leigh, feel free to jump in here to answer this. The first question was, can one NAPRC accreditation be attained for all 3 legacy hospitals as they share the same COC accreditation or the same FIN number? Leigh or Dr. Simpson, would you like to jump in here?
Sure, I can answer that for you. At WellStar, we do have 2 integrated network programs, one with 5 facilities and one with 2 facilities. However, NAPRC is a facility-specific accreditation, much like NAPBC. You can only, you have to seek individual accreditations for each facility.
Great, thank you. Another question that we received is the T3 MRI, is that mandated by the NAPRC?
I can answer that. That is not on the Cancer Answer Forum. It is, they have answered that question, that they don't specify whether it should be a 1.5 or a 3T magnet.
Great. We have one question, a very interesting question here. What does a facility do without the OncoLens software? So how can the NAPRC accreditation process be managed without the solution? Leigh, would you like to take this maybe?
Sure. The best way that we were able to come up with a solution prior to using OncoLens was using calendars and Excel spreadsheets. And those were very very manual, very time consuming. It was a lot of information in one system or in one spreadsheet that you had to keep up with it. But it was just, we did not find that was the best use of our time, as well as making sure that we were meeting all of the regulations and all of the standards.
Great, thank you. Another question is, who would you recommend to serve as the NAPRC coordinator?
So the NAPRC coordinator has to be able to interface between the program, the patients, the multidisciplinary team, and that should be somebody who has the leadership skills and the ability to interact with multiple disciplines. Ideally, it probably should be somebody who is already established within the program, maybe at a slightly more senior role. And every program will be different as to who they find to fill that particular resource. But that individual should be able to run this program, so it should have a full set of skills to run a program, interface with patients, departments, make sure the metrics are being collected, generate reports, look at which metrics are not being adhered to, and try to implement changes so that those metrics then enter back into compliance.
Thank you. We have a question here that I can probably help answer. What is the startup and maintenance cost for OncoLens? This is dependent on the size of your facility. So if you would like to just send us your information, you can send it to the organizer and that can be sent over to us. We'd be happy to reach back out to you with that information. Or please feel free to email us directly. The email ID is info@oncolens.com. That's info@oncolens.com. There was another question around how does the OncoLens documentation get into the EMR? Again, dependent on your system, the documentation can be pushed back into the EMR as a PDF document. I have a question here around accreditation. So did you say there was a module physicians needed to complete for accreditation? Dr. Simpson?
Yes, thank you. I can answer that. For the rectal cancer surgeons, there is a module that they have to go through and complete. It is there on the NAPRC standards manual. The pathologists have to attest that they have reviewed the College of American Pathology's synoptic reporting for colon and rectal cancer. The radiologists have to undergo training or attest that they have read a module for radiologists, in particular those who are going to be reading the MRIs to accurately stage patients with rectal cancer. So those three modules have to be completed by the providers.
All right. How much is the cancer registry involved in the process? Leigh, would you?
Well, as the accreditation manager at WellStar, I also do manage the cancer registry. So we are involved quite a bit with helping to identify patients. We work with the coordinator to identify patients who come in with rectal biopsies or surgeries, so that we are making sure that we're identifying every patient that needs to be presented to the rectal cancer program. As far as anything from the registry itself, you're not going to be providing a lot of information because this is a very clinical accreditation and doesn't rely as heavy on programmatic and operational things as the CERC accreditation does.
I have another question for Leigh. How much time do you find the program coordinator and program director spend in the program?
That is going to be highly dependent on the number of cases that you have in your program. On the front end of it, while you're still developing processes and workflows, it's going to be quite a bit of time. I can't say that might be a 1.0 FT or a 0.5. It's going to depend a lot on your program. But once you get the workflows going and and those that are working smoothly, then the time that's involved becomes less and less. We do have a lot of coordination at our facility because a good amount of our patients are diagnosed outside of the system. So there is some information sharing and pathology reports, pathology slides that we need to get from outside institutions. So, there is some administrative work done as well.
And we have two adjacent questions. How much is the cancer registry involved in the process, and is it practical for one registrar to coordinate the COC, NAPBC, and NAPRC accreditations?
As far as the rectal program coordinator, I would not recommend a registrar be that person. That person needs to have a pretty strong clinical background as well, being able to meet with referring physicians to discuss workflows. And again, depending on the size of your facility, I, as one person with a team, manage 2 network accreditations, an NAPBC. We're in the process of obtaining another NAPBC and this NAPRC. So, I'm, as the manager's department, I do have a team behind me working with this, but it's largely depending on the size of your program.
Now, some of the standards say in process. Has the NAPRC provided any update to the standards since then? I'm assuming the standards, the draft standards came out in May.
The draft standards we showed was just a screenshot from the upcoming COC standards that will probably be released shortly before the COC conference in November of this year.
All right, sounds good. It looks like that's it for questions. Well, thank you all very much for your time today. And as you can see on the screen, you can see our contact information, both for Dr. Simpson as well as Dr. Webb. If you have any questions about OncoLens, you can feel free to reach us at info@oncolens.com. You can also send additional questions to the organizer at ACE. Thank you all for your time. Jen, back to you.
Thank you all for attending, and thank you to Lijo, Leigh, and Anju for your participation. Again, their contact information is on the screen if you have any specific questions for them. And as I mentioned previously, the webinar has been recorded, and both the webinar slides as well as the recording will be available in the members only section of the ACE website. So please stay tuned as we have some other 2 more great webinars coming up before the end of 2019. Thank you so much, and I hope everyone has a fantastic rest of your day.